of some of the common inflammatory disorders. So the first case is a 42-year-old female who presented with chronic dyspepsia, and on scopy she had a small ulcer in the antrum, 1 to 2 millimeter. The mucosal biopsy is from the antrum. And I'll request Dr. Jayashree to start the description on these low power images. Dr. Jayashree, would you like to say something?
Yes, ma'am. This slide shows 4 images, of which first image shows some architectural distortion with one ulcer, and below that 2 images shows mild atrophy of mucosa, and lamina propria shows inflammatory infiltrates.
Okay. Yeah, so you're mostly right on that. But are you saying that the ulceration is by this area? This area is what you're calling
Yes,
an
ma'am.
ulcer? Okay.
Yes, ma'am.
So the first lesson to learn today is that in an ulcer on in a mucosal biopsy, just having absence of the surface epithelium doesn't make it an ulcer. Okay. The biopsy process itself, sometimes the biopsy may be poorly oriented, or the biopsy may be fragmented, or they may have pulled off the surface epithelium. So to actually say that there's an ulcer, you have to see some inflammatory exudate here, or you should see necrotic material, or you should see granulation tissue. So since we're not seeing any of those, we're not seeing inflammatory exudate, we're not seeing granulation tissue or necrotic material. So this is not a true ulcer. So there is no ulcer seen in this biopsy. That's also a message to know that often when a clinician takes a biopsy from an ulcer, the ulcer may not appear in your mucosal fragments because the scope sometimes slips. So often they may not give you the ulcer, but often it's more useful to have the mucosa adjacent to the ulcer, because that gives you the clues to what it is. So now you have described correctly that there is some inflammation. There seems to be some architectural alteration. But now the other point I want to make here is that you can't evaluate architecture properly when the muscularis mucosa is not present. So all these biopsies are superficial. So we cannot evaluate glandular atrophy on this biopsy. You are seeing glands here, okay? You're seeing glands here in the lower part. In all the fragments, you are seeing some glands, but we don't know whether there is a full complement of glands or not. All we know is that there are glands. So by looking at these fragments, can you say which kind of mucosa this is? They said it was antrum. Is it really antrum? Dr. Rachana, do you think this is antral mucosa?
Yes, ma'am.
How do you know it's antral mucosa? What kind of glands are you seeing?
Ma'am, these are gastric glands I'm able to see in this.
Okay. What are the two kinds of gastric glands? In the antrum and in the cardia, you see a certain kind of glands. No, what are those?
Yes,
mucus secreting glands. Okay.
Yes, ma'am. Mucus secreting.
So are these mucus secreting glands, or are they the body glands, which are parietal glands, which have parietal cells and chief cells? What kind of glands are these?
These are body glands, ma'am. Parietal cells and chief cells.
Would those be pale in color or dark pink in color?
Ma'am, dark pink in color.
So are these glands, are they pale or dark pink, these glands?
Pale color, ma'am.
Okay, this is a higher magnification. You can see these glands. Are they pale or are they pink? Are they dark pink? Are they having parietal cells or mucus cells?
Dark pink parietal cells, ma'am.
Okay, would Dr. Jayesh, who else would like to comment on that?
Yeah, I'm mucus secreting glands.
Okay. Mucus secreting glands. So, okay, so these are actually pale mucus secreting glands. These are antral glands. Okay, so who started off? Was it Jayashree?
Yes, ma'am.
What will you comment at this magnification? What can you say?
Ma'am, at this magnification, on left side image, we can see lamina propria infiltrated with mononuclear cells, lymphocytes.
Yeah. Lymphocytes and plasma cells, difficult to tell at this magnification. Any other change you're seeing here? Okay, we'll go to the next magnification. Okay, at this magnification, what can you see?
Some architectural distortion of...
okay, the foveolae are a little bit dilated and they're tortuous. They're not looking straight. And,
Yes,
with a narrow lumen, which you normally should see. So they're dilated. So there is some kind of distortion of the foveolae. What about here? What do you see?
Ma'am, there are some microorganisms.
Are these microorganisms here? Anybody else? Dr. Rahul,
Then,
what kind of cells
yes,
do you see?
Then these are basically neutrophils which are infiltrating the epithelium.
Okay, so there are neutrophils infiltrating the foveolar epithelium. Okay, this is the foveolar epithelium. And this is the surface epithelium. Does it look normal or abnormal?
Some abnormal.
Yeah, so there is actually mucin depletion. Normally the epithelium in the stomach, and I'll show you the normal epithelium, has a lot of mucin in it. So here there's mucin depletion, there's foveolitis. And what about the lamina propria? Here you can see the plasma cells and plasma cells here. Okay, so there's chronic inflammation, there's neutrophils, which will be called activity, there's mucin depletion. Okay, and this is another area. Here you see the normal pyloric glands, antral glands. Here the foveolae. And here you see, can you see some glands which look a bit different?
Yes, ma'am. Oxyntic.
Yeah, they look more pink, right?
Pinkish.
Yes,
Pinkish.
So can you get oxyntic glands in the antrum?
No, ma'am.
Normally you can't. You can get parietal cells, but you can't get oxyntic glands. You can get some parietal cells. Okay, so this is an open question to the audience. What do you think is the most likely cause of this gastritis? Is it A, B, C, or D? Dr. Vatsala or Dr. Sindhura?
Yes, ma'am. We are looking for the answers, ma'am. We'll read out if they reply. Mucus cells, pale ones. Some have given H. pylori.
Okay. Is
Mixed
anybody who
abscess.
thinks it's not H. pylori? Jayashree, what do you think?
Yes, ma'am.
Which kind of gastritis is this due to?
Ma'am, active chronic gastritis. I
Okay,
think
that's the description, the summary of the type of gastritis, but what kind of
H. pylori induced. I
H.
think.
pylori induced? Why do you say that?
Because active in chronic active infection in chronic gastritis.
Okay, yeah, so the answer
Most
is correct.
probably
This
in
looks
H.
like
pylori.
an H. pylori type. So impression will be, what will be your final impression on this biopsy? What
Ma'am,
do you see?
if there is a middle-aged patient and a biopsy from antrum shows lymphocytic infiltration and some neutrophilic infiltration also, which shows active infection in chronic gastritis, and some mucin depletion and oxyntic cells also seen.
Okay.
So I have
Okay, so this is the next open question. What type of cells do you think the arrows are pointing to? Body type, which you said oxyntic, antral type, intestinal type, pancreatic type.
Pancreatic type. Some have given as pancreatic type.
Yeah.
Some have body type glands.
Yeah.
Most of them for option 1.
Okay, so actually, yeah, the differential is body type, but actually these are pancreatic type. I'll just show you the different kinds of epithelium. This is actually pancreatic metaplasia. If you look closer, there's granular pink cytoplasm above the nucleus, but below the nucleus, there is no pink color. Okay, so the pink color is seen only when there is below the nucleus. If you see pink, only then it is parietal cells. If you don't see pink color below the nucleus, then it's more likely to be pancreatic cells. Okay, so this is how the normal parietal cells look. You see the nucleus here, there's pink all around the nucleus. Okay, you take another nucleus here, there's pink all around it. Every nucleus has pink all around it. But in intestinal metaplasia, if you have Paneth cells, then you have orange granules above the nucleus. But in pancreatic Asana type metaplasia, you don't have the pink color all around, only above the nucleus. So that's how you know it's pancreatic and not body type glands. Okay, so our impression on this will be mild chronic gastritis, because chronic inflammation is only mild, with activity and focal pancreatic metaplasia. So what special stain will you ask for to clinch the diagnosis?
Barthes.
Good.
Warthin
Modified
Starry.
or Warthin,
Starry
but Warthin Starry is
Starry
too
fevers.
expensive. It's not a practical stain for people in India.
Yes,
Okay,
ma'am.
so here we do a modified.
Yes, sir.
Warthin. What are you seeing here? Jayashree,
Yes, ma'am.
what are you seeing here?
Ma'am, road shaped
Are they rod shaped?
curved coma shape, ma'am.
Yeah, curved. These are not comma. These are actually
Okay.
curved bacteria. Okay,
Yes,
with a small twist, like almost like an S shape.
Yes,
Okay,
ma'am.
so these are the typical H. pylori organisms. So this is H. pylori associated mild chronic gastritis with moderate activity because of the amount of acute inflammation, focal pancreatic metaplasia. Okay. So when you look at H. pylori associated gastritis, there are different stages to what happens in the mucosa with H. pylori. In the first stage is acute gastritis. Normally you don't see that because it's so transient. And then you get a chronic gastritis initially where the inflammation is only in the superficial part of the mucosa. Then the inflammation goes into the deep part of the mucosa. When it goes into the deep part, it destroys the glands and causes atrophy. And it can also cause an ulcer if the surface epithelium is damaged. Then once you get atrophy or at the damage of the deep part, you get intestinal metaplasia, which are different types. And in incomplete intestinal metaplasia, it can go on to dysplasia and carcinoma. Sometimes the inflammation will have lymphoid follicle formation, and that eventually in a small subset of patients, you can go on to mild lymphoma. So now H. pylori is actually classified as a carcinogen. Okay, it's extremely important to be able to diagnose it so that you can tell the clinicians and they can treat it and cure the patient. If as pathologists we don't pick up the H. pylori correctly, then the patient can go on to develop all the complications of H. pylori associated gastritis. So this is acute gastritis, only neutrophils. There is no chronic inflammation. There may be some congestion, hemorrhage, destruction of the epithelium, and a superficial erosion with neutrophils. See here, this is a real erosion, a real ulcer where the epithelium is missing and that area is replaced by neutrophils. Okay, so this is a typical acute erosion. So this is acute gastritis. But more commonly, H. pylori presents as chronic. So in normal antral mucosa, get a few inflammatory cells. In the early stages of H. pylori associated mild chronic gastritis, you get superficial inflammation. As it becomes more chronic and more advanced, inflammation goes into the deep part of the mucosa, can destroy the glands and cause atrophy. And sometimes that atrophy is associated with intestinal metaplasia. So this is the full spectrum of H. pylori associated chronic gastritis. Okay, it affects up to 90% of the population in some countries. And in most people, H. pylori infection is asymptomatic. Only a small subset will have symptoms and about 15 to 20% develop ulcers. But it's important once they get the ulcer, you have to diagnose H. pylori and treat it and eradicate it to prevent recurrence. Okay, some features of H. pylori associated gastritis are mucin depletion. Mucin depletion, this is the normal surface epithelium. Here you see how there's no mucin. The other thing, of course, is activity. So when the neutrophils come in the foveolae or in the surface epithelium, that's called activity. And this is what we grade as mild, moderate, and severe. And neutrophils in the foveolae and surface epithelium are suspicious of H. pylori infection. It's the most common cause of activity. Atrophy is when we talk about glands only. We never talk about atrophy of the foveolae. And normally there are much less foveolae than glands. So though it looks like there's a big gap between these foveolae, that is not atrophy. This is a normal gap. But between the glands, there should not be any gap at all. When this kind of a gap comes, where glands are missing, then that is called atrophy of glands. It may or may not be associated with intestinal metaplasia. So intestinal metaplasia is when the normal gastric epithelium is replaced by intestinal type epithelium, and it can either be complete when the entire epithelium is replaced by intestinal type here. See, so here you see goblet cells, absorptive cells, and Paneth cells here. But here you see the goblet cells are interspersed between gastric epithelial cells. This is incomplete and this is more dangerous. And you can use various special stains to distinguish these different types of intestinal metaplasia. So this particular stain, Alpas, picks up all acidic mucin. So small and large intestinal mucin both are acidic, and it'll show positive on Alcian blue. But Alcian blue high iron diamine, that stains only intestinal mucin. It's the more dangerous type, and that will be seen with the Alcian blue high iron diamine stain. In practical pathology, we don't need to do the stain to identify intestinal metaplasia. Histologically, you should be able to identify it. Okay, so this is again intestinal metaplasia associated with severe atrophy. So that there's no major gap here, but the glands are missing. So these glands should have been here. They're not there. So there is severe atrophy of glands in this area. Okay, acina metaplasia is actually much less common. They usually appear in nests or lobules, may be seen in up to 1 to 2% of biopsies. Usually antrum or pylorus also at the GE junction. It's just indicative of chronic gastritis. So when you look at a gastric biopsy at low power, first you look at the kind of mucosa, is it body or antrum, you look for ulcers, you look for lymphoid follicles, and then you try to stage the gastritis. Is it only superficial? Is it deep? And then this is how, so this is not a real ulcer. There's no exudate. But here, like I said, there's an acute ulcer, neutrophils. Here, this is a chronic ulcer, epithelium missing, and instead there's necrotic material and IgT. Okay, and then under high power, you look for changes associated with H. pylori, like mucin depletion, activity, atrophy, and chronic inflammation. Okay, and of course, in some cases, there may be other lesions like granulomas or dysplasia and carcinoma. Okay, so the Sydney grading system originally used the number of foveolae or the number of glands affected as 1/3 to 2/3, more than 2/3 for grading gastritis. But then this visual analog scale came up, and this is the scale that is currently used for grading the different histological variables of chronic gastritis. So in any case of chronic gastritis, you should evaluate, are there a lot of H. pylori or only few? Lot of neutrophils or only few? Lot of mononuclear cells, lot of atrophy, lot of intestinal metaplasia. All these the clinicians usually would like to know. Is it mild intestinal metaplasia or severe intestinal metaplasia? Because it makes a difference to the follow-up. If it's only mild, not much to worry about. But if it's severe, then that person is more likely to go on to dysplasia and carcinoma. So your report ideally should have all these things described. This is another grading and staging system that's come up more recently, but not used very much. I don't think you need to worry about it. But in case anybody asks you, it's again based on the amount of atrophy, both in the antrum and in the body. Okay, so we go on to the second case, which is a 46-year-old male who presented with anemia. And the scopy did not find any remarkable changes. And the clinicians have taken biopsies from the antrum and the fundus. So I'll ask Rahul to describe this. Okay, so there's an antral biopsy and then biopsies from the body.
Yes,
Rahul, what do you think you're seeing?
Yes, ma'am. Antral biopsy.
Yeah.
We can see the architecture is normal. We're seeing foveola and glands, and but there is inflammatory infiltrates.
Yeah. Mild inflammation here, no?
Yes, ma'am.
Okay. Now what about the body?
Body is a bit disoriented here, but architecture. But we can also appreciate the atrophy of the glands here,
Very
and
good.
apart from that, we can also see inflammatory infiltrates.
Okay, good. Okay, at this magnification, that's all we can appreciate. Now, this is a higher magnification of the antral mucosa. Like you said, the architecture is normal. So the foveolae occupy about half the height of the mucosa. Glands occupy about half. No real gap between the glands. And inflammation is very minimal. It's almost normal. This is from the body. So here, what are you seeing? Are you seeing any normal body glands?
No, ma'am.
No, not seeing any
No.
normal body glands. Rahul, do you agree?
Ma'am, we can appreciate the glands, but mostly are seen along with the infiltrates.
The normal body glands, remember, they look very pink in color, right?
Yes, ma'am.
So normally they should have been very closely packed, crowded glands, all with parietal cells. But instead here, you're seeing a lot of mucus producing glands. And then you're also seeing, what are these glands?
Intestinal like
This,
glands.
yes, ma'am. Intestinal
Yeah.
metaplasia.
Yeah, so actually there's a severe atrophy of the body glands, almost total atrophy, no normal body glands. Instead, there's a lot of pyloric or pseudopyloric metaplasia and focal intestinal metaplasia. Okay, so this is the intestinal metaplasia, this is the pyloric metaplasia. And then here, can you see some nests of cells also?
Yes, ma'am.
Okay, so that's also abnormal. So what's your impression?
Ma'am, this is a chronic gastritis.
Yes?
We are not seeing any neutrophil also
Okay, good.
with intestinal metaplasia. Ma'am.
Okay, so you have to specify, was the antrum affected or the body? Which one is predominantly affected?
Predominantly affected is body part.
Okay, with severe atrophy?
Severe atrophy and intestinal metaplasia.
Yeah, and extensive pseudopyloric or pyloric metaplasia. Okay, so this is the normal antral mucosa. This was in our case, it looks almost the same, right? It's normal almost. Now, this is the normal body mucosa, closely packed glands with parietal and chief cells. But this is how ours looked. So can you make out total loss of glands and pyloric and intestinal metaplasia? And then, as I said, there are these nests of cells. Okay, do these remind you of some other kinds of cells? Rahul, in any other lesion in the body, do you get those kind of cells? How are they? Uniform round to oval nuclei, moderate amounts of cytoplasm.
I thought these are lymphocytes.
Okay, but they have pink cytoplasm, right? And it's forming a nest. Here also it's forming a nest. Okay, let's just go on. So the impression is this. Antrum has no lesion, nothing, it's normal. But the body has severe chronic gastritis, severe atrophy, intestinal and pyloric metaplasia. Okay, now would you do any special stains in this case? You have to rule out anything. What do you have to rule out? Now, if you ask me, I would do a modified GIMSA because I would definitely have to rule out an H. pylori associated gastritis. Okay, we have to rule out that H. pylori is the cause. So we will do a GIMSA stain even though there is no activity. And the next thing is because of those nests of cells, I feel they look like neuroendocrine cells. Okay, so I will order a synaptophysin and see what I saw on synaptophysin. What am I seeing? Normally,
False
there are so
positive.
many endocrine cells. Yeah, normally, are there a lot of endocrine cells in the body?
No, ma'am.
No, they're
Mostly
only scattered.
Scattered.
Okay, yeah, but here you're seeing nests of endocrine
Endocrine
cells.
cells.
So in this particular patient, there is a severe chronic gastritis with severe atrophy and all the metaplasias with endocrine cell hyperplasia. And this is the classic picture of autoimmune gastritis. Okay, with or without endocrine cell hyperplasia. Okay, antral sparing, severe body gastritis. If there's endocrine cell hyperplasia, then it's most likely to be autoimmune gastritis. So this is a question for the audience. Neuroendocrine tumors can develop in autoimmune gastritis. Which of these points are correct, or which one point is correct?
Option 4.
Okay, is that what everybody's saying?
Yes, ma'am.
Okay, so they're correct. Okay. Neuroendocrine tumors develop about in 5% of patients with autoimmune gastritis. They're found in the end stage of autoimmune gastritis. They have a very good prognosis. Okay, more than 95%, 5-year survival. Okay, so basically autoimmune gastritis has different stages. In the early stage, it will be focal atrophy, mild intestinal metaplasia. In the florid stage, you get severe atrophy and metaplasias with endocrine cell hyperplasia. In the end stage, the glands are almost completely disappeared and there's ECL cell hyperplasia with less inflammation. So in this particular case, it's between 2 and 3.
2 and 3.
So it's like the end stage of autoimmune gastritis. Okay, so what happens in autoimmune gastritis is because of the loss of parietal cells and acid production, there's hyperplasia of the endocrine cells that stimulate the parietal cells. So gastrin producing cells in the antrum undergo hyperplasia. Those gastrin producing cells in turn stimulate the endocrine cells in the body that secrete histamine. Okay, so these are the cells, these endocrine cells, these ECL cells are the ones that proliferate in the gastric mucosa in autoimmune gastritis and ultimately give rise to the gastric type 1 neuroendocrine tumors. Okay, with a good prognosis. Okay, we'll go on to the third case. This has got only very few findings, but it's a classical case. Okay, so 37-year-old male who had chronic liver disease. The scopy showed some erosions in the body and the antrum, mucosal biopsies from body and antrum. Okay, who would like to answer this? Shall I ask Manjula?
No.
What kind of mucosa are we seeing, Manjula?
This is biopsy from the body because the glands are tightly packed and
Good.
they look oxytic, more pinkish.
Okay, good.
Eosinophilic.
This one? The other biopsy?
The other biopsy is from antrum because the glands are loosely packed and we could see more of mucus secreting glands.
Okay. What about inflammation, atrophy? Are you seeing anything?
There is no atrophy, ma'am, but mild to moderate inflammatory cells are there.
Okay, good. In this higher magnification, what do you think? Not much atrophy. And as you said, there's some inflammation in the lamina propria.
Lamina propria.
Okay, now this is higher magnification. Okay, we'll go to the highest magnification. So what are you seeing now? Are you seeing the mucin depletion of H. pylori associated gastritis?
Yeah.
Do we see any mucin depletion? No, there's a good mucin component here. Okay, here there seems to be a little bit of depletion, but generally the mucin is preserved. So are we seeing any foveolitis?
Yes, ma'am.
Are we seeing neutrophils? Are we seeing neutrophils?
No, lymphocytes are predominantly seen.
Yeah, so there are a lot of lymphocytes, no neutrophils. Okay, is there any chronic inflammation in the lamina propria? Little bit. Okay,
Yeah.
there's some
Mild.
lymphocytes, a few occasional plasma cells here and there. But the inflammation in the lamina propria is not so prominent, but it's mainly lymphocytes inside the epithelium. Okay. See again, can you see the lymphocytes?
Yeah.
Can everybody see?
Yes, ma'am.
So the lymphocyte nuclei look different from the epithelial cell nuclei, which are elongated and paler. The lymphocytes are dark, round and oval and often have a little halo around them.
Yes.
Okay. Yeah, so there are lots of lymphocytes in the epithelium. So what's your impression?
Lymphocytic gastritis.
Okay, very good. Yeah. So this is a very straightforward case. The only change we're seeing, and we also have to do GIMSA to rule out H. pylori. In this case, there were no H. pylori because you can get increased lymphocytes with H. pylori. So this one didn't have any H. pylori. So then our diagnosis will be lymphocytic gastritis. Okay, it's a mild chronic gastritis with increased intraepithelial lymphocytes or lymphocytic gastritis. So now I have an open question for the audience. How many lymphocytes do you need per 100 epithelial cells to make a diagnosis of lymphocytic gastritis?
Most of them are giving the answer as option 4, more than 25.
Okay, very good. So actually the normal number of lymphocytes in a biopsy is up to 5. But if you get more than 25, then you can call it lymphocytic gastritis. Sorry. Answer is 25, correct. Okay. So when you classify gastritis, the Sydney classification system classifies gastritis as acute and chronic. And chronic is H. pylori associated and autoimmune. We've seen those. And then there are special forms of gastritis. Chemical, lymphocytic, eosinophilic, various infectious and non-infectious causes. So the classification of gastritis is based on the etiology. So here it's H. pylori associated, autoimmune, chemical, eosinophilic. But it may also be based on the morphology, how it looks, like lymphocytic and eosinophilic are based on the morphology or on the topography. So which part of the stomach is affected. So for the ideal gastric biopsy for inflammatory disorders, you take 2 biopsies from the body, 2 from the antrum and 1 from the incisura. You put the body biopsies in one bottle, antral biopsies in one bottle, and the incisoral biopsy in one bottle. The reason why you take the incisura is because many changes start first in the incisura. So even if the antrum and body look normal, the incisura will look abnormal. So atrophy, intestinal metaplasia, dysplasia, all start in the incisura. Okay, so H. pylori related, normal H. pylori related gastritis usually starts in the antrum. Okay, reactive or chemical gastritis also affects the antrum. But there's a kind of H. pylori associated gastritis where you get multiple foci of atrophy here and there, both in the antrum and the body. That is called multifocal atrophic gastritis. And unless you have biopsies from the body and the antrum, you won't know that this is affecting the whole stomach. Then you get a body predominant gastritis, which is what we saw, autoimmune gastritis. Here the antrum is spared and the body is affected. Okay, so in our case, actually it's a body predominant gastritis that we had with severe atrophy, pyloric and intestinal metaplasia. So the morphological types, when you look at acute versus chronic, it's based on what kind of cells are predominating. So in the acute gastritis, you should hardly get any chronic inflammatory cells. Like here, just 2 or 3 plasma cells are there, but mostly it's neutrophils. Whereas in chronic gastritis, most of the types of chronic gastritis, you get increased plasma cells and lymphocytes in the lamina propria. And H. pylori associated versus reactive. And reactive gastritis is a type of chronic gastritis. Some people call it reactive gastropathy because there's no inflammation. So you don't get chronic inflammation in the lamina propria in reactive. Whereas in H. pylori and autoimmune, you get a lot of chronic inflammation. Okay, so lymphocytic gastritis is not a common condition. It's also called varioliform, and it's associated often with these umbilicated nodules. Okay, it's usually seen in the older age group, presents with dyspepsia, and different conditions can be associated with lymphocytic gastritis. So before you diagnose lymphocytic gastritis, or when you diagnose it, you should look out for all these other conditions: H. pylori, celiac, menetriers, lymphomas, HIV, Crohn's, inflammatory polyps, and even carcinomas may be associated with lymphocytic gastritis. So you should always look for all these other conditions when you see lymphocytic gastritis. Okay, and usually it may or may not be associated with erosions, nodularity, ulcers, scars. Sometimes you have giant gastric mucosal folds, and usually it affects either the body or the antrum. Okay, and mature lymphocytes, more than 25 per 100 epithelial cells, there may be some inflammation in the lamina propria, there may be ulcers and erosions. The cells are mostly CD8 suppressor T cells. And often lymphocytic gastritis associated with H. pylori or celiac. The most common conditions, you must always do a GIMSA to rule out H. pylori. Okay, this is the CD8 stain for that. Okay, so going on to the 4th case, this patient didn't present with any GI symptoms. I mean upper GI symptoms, had only chronic diarrhea with a raised CRP. And scopy was normal. Biopsies were taken from the antrum and the incisura. Okay, shall we go to Ishan?
Yes, ma'am.
Okay, what are you seeing, Ishan?
And this is a HNE section from the antral part of the stomach, ma'am. I can see on a first look, I can see a dense inflammatory infiltrate at the base of the foveola. I can also see a bit inflamed mucosa, which is atrophic, mildly atrophic at some places. And I can see collection of epithelial cells, not something like granuloma formation at the base of foveola. Yes, ma'am.
So now the first thing is, actually, I don't think there's much atrophy in these images. Okay, I think you're looking at the gaps between the foveolae. See, like this gap. You're looking at this gap.
Yes,
you're looking at this gap, but you don't evaluate the gap between foveolae when you're talking about atrophy. You evaluate only the gap between the glands in the lower half. Okay, so really maybe here 1 or 2 glands are missing, but generally it's not an atrophic gastritis, but there is, as you say, chronic inflammation and some looks like some pale areas which could be granulomas. Okay, so this is another field, slightly higher magnification. Do you have any comments on this area?
Again, inflammation is evident from here. I can see lymphocytic number of lymphocytes.
Okay.
From in this slide, yes, which you are pointing at, I can see lymphocytes and.
What about these cells? Can you see something with smaller nuclei? Are there any neutrophils here? These actually are neutrophils. Maybe we'll see it at a higher magnification. Okay, we're not seeing that. Okay, but that was actually neutrophils. And now what you said. Okay, what are these?
Ma'am, granulomas here.
Okay, how would you describe these granulomas?
And they are collection of epithelioid cells and lymphocytes.
Okay.
So on higher magnification, one can see the epithelioids which are slipper shaped, and yes, ma'am, this is on the third slide. I can see a typical granuloma.
Okay.
And
any
I
other
can see
comments
the
about this? What else you have to talk about when you describe a granuloma? What else should you say?
Giant cell.
giant
Giant
cells,
cells,
ma'am, I
okay.
can see.
Necrotizing or
Necrosis.
non-necrotizing.
Okay, whether there's necrosis, very good.
Caseating, non-caseating.
Okay, yeah, that's necrotizing. Caseation is a better word for when you're thinking of TB. So what's your differential diagnosis at this stage?
And it can be tubercular.
Okay, so what are the classical features of granulomas in TB, if you were saying that?
Creating granulomas are there. There are giant cells, Langerhans giant cells are there.
Okay, anything else? Now, what's a differential diagnosis?
And it can be Crohn's disease.
Okay, so how will you differentiate TB from Crohn's, granulomas? Anything to do with the size? Other than caseation? What about size of granulomas? Crohn's granulomas tend to be big or small?
Small. It is the granulomas are a bit big in tuberculosis, and they are small in case of Crohn's.
Okay, what about confluence? Confluence is more likely in TB than Crohn's. Okay, can be seen in Crohn's, but more likely. What about a lymphoid cuff?
I mean, that will be evident in TB, tuberculosis.
More common in TB than in
Yes,
Crohn's
ma'am.
disease.
Yes, ma'am.
Okay, what about fibrosis? Fibrosis more common in TB than in Crohn's. Okay, but one thing is, in the mucosa, granulomas usually don't have fibrosis. So there are two granulomas close by. They're not yet confluent, but there are two granulomas. Here's another granuloma. Are these big or small?
And these are big, I can
Actually, they're small. They look big because I took it under high power. Okay. But they're actually small granulomas, just less than 1/3 the height of the mucosa or half the height of the mucosa. Okay. So no
Okay.
lymphoid cuff, no caseation or necrosis, no inclusions. Okay. Some aggregates of histiocytes which are not really a granuloma, this area. Okay. You're seeing some histiocytes, but they're not forming granulomas. So what's your impression now?
And it can be case of Crohn's.
Oh, no, you have to tell a description. How do you give an impression in a case like this? You won't say Crohn's disease straight away. What will you say?
And chronic granulomatous gastritis.
Yeah, I think that's a good way of saying it. Or you can say chronic gastritis with activity and granulomatous inflammation, because I told you there were neutrophils there. Okay.
Yeah.
So mild chronic gastritis with focal activity, there was actual focal atrophy and granulomatous inflammation. Okay, antral and incisional mucosal biopsy. So when you see granulomas in the gastric mucosa, there are a large number of conditions which may be associated with granulomas. So among the infections, TB most common, but you can get all the others. Among non-infectious causes, Crohn's disease, and now sarcoidosis is becoming more common. Okay, so sarcoidosis, foreign body granulomas in the gastric mucosa because of any food that goes in through an ulcer, or vasculitis, and all these other conditions. Have you heard of chronic granulomatous disease? This is a congenital immune deficiency disorder that
Yes.
also can be associated with granulomas. Previously, they used to say there's a primary granulomatous gastritis, but now we don't diagnose anything as primary granulomatous. Everything is, we try to put it into one of these categories. Most common will be TB, Crohn's disease, and foreign body granulomas. So in this particular patient, he also had lower GI biopsies, and this is what the ileal mucosa showed. What is this? And a collection of histiocytes and epitheliocytes.
Epithelioid cells.
Yeah, it's an ill-defined granuloma. It's not a
Ill-defined.
well-formed granuloma, small,
Well-formed.
ill-defined granuloma. Okay, this is the colonic biopsy. What are we seeing? Okay.
With superficial.
So now that you have granulomas in the upper and lower GI tract, would you diagnose tuberculosis or Crohn's disease? Is there any condition in tuberculosis where you can get granulomas everywhere? Only miliary. Usually only miliary. Okay. So unless the patient is extremely sick, and then I think you may get acid-fast bacilli also. But in this case, there were no acid-fast bacilli and the patient was not very sick. In fact, remember the scopy was normal. So this is more likely to be Crohn's disease. Okay. So this is an open question for the audience. What are the most common microscopic lesions in the gastric mucosa affected by Crohn's?
Majority are giving it as option A.
Okay. Aphthous ulcers,
Some have also given option D
D, lymphoid follicles.
and C, focally enhanced gastritis.
So the answer is C. Okay, and I'll show you an image of what that looks like. But basically, the upper GI tract is not usually involved in Crohn's. It's symptomatically involved only in 1 to 5% of Crohn's disease. But asymptomatic involvement, like in this patient, there were no upper GI symptoms, but there were granulomas, activity, chronic inflammation. That may be seen in a large number of patients with Crohn's disease. So they may not have symptoms, but there's involvement of the upper GI tract. And this is more common in children than in adults. On endoscopy, you may get aphthous ulcers at an early stage, but actually at the early stage, you don't get any change at all. On scopy, you don't get any change at all. Only in very, very few patients, you get ulcers, and then in end-stage upper GI involvement, you get antral outlet obstruction. Okay, so the most common and early lesion in Crohn's disease in the stomach is focally enhanced gastritis. Okay, so where there's focal involvement of a few foveolae or glands. So can you see how the neutrophils are infiltrating only these few glands, not infiltrating these, and around them there's a little bit of chronic inflammation. So it's called focally enhanced gastritis. And it's seen in 30 to 40% of patients with Crohn's disease, more in children than adults, more common in the body than in the antrum. Granulomas actually are not so common. They're seen only in 10 to 15% of patients and are more common in the antrum than in the body, granulomas. Okay, gastric Crohn's disease, only in severe cases, you get all these other changes, atrophy, lymphoid follicles, fissures, ulcers, fibrosis. Non-caseating granulomas may be seen in only about a third of even severe cases. So focally enhanced gastritis is the most common lesion in early Crohn's, but unfortunately, it can also be seen in H. pylori associated gastritis. It can also be seen in people with ulcerative colitis. It can also be seen following bone marrow transplants. So there are multiple causes of focally enhanced gastritis, and you have to rule out all the other causes before you even give a suspicion of Crohn's disease. Okay, so we'll come to the last case. This is a 51-year-old female who presented with epigastric pain and decreased appetite for 2 years. Okay, vague, long-standing symptoms. Scopy showed nodularity of the gastric mucosa and loss of the normal folds with poor distensibility. Okay, something happening in the wall that is not permitting it to distend properly. Biopsy from the body and the antrum. Okay, so who has not described? Is it Rachana?
Yes, ma'am.
Okay, so Rachana, what do you think?
Ma'am, this is studied from stomach mucosa. In this, we can able to see mucosa, lamina propria, and some layer of submucosa. This slide, and we can appreciate inflammatory cell infiltrates in lamina propria, like plasma cells and eosinophils are there. In mucosa, edematous mucosa, it is.
Okay.
We can able to edema.
Okay, good. So you're saying there's inflammation. Is there any atrophy?
What
about this gap?
Yes, ma'am.
There's a gap here, right?
Yes, ma'am. Gap in between.
Some atrophy. Okay.
Yes,
What about these things? What are these? Is this normal?
No, ma'am. Dilated that thing.
Yeah. So this is a feature of atrophy with loss of glands. The remaining glands are very dilated.
Dilated.
And there's a reason for the dilatation. We'll look at it later. So again, hyper, you can see here that there's a gap between the glands here.
Yes.
And in that gap, there's a lymphoid follicle. Okay.
Yes.
So this is focal atrophy with lymphoid follicle formation, chronic inflammation in the lamina propria above. And here also that the normal number of glands, see, this is how this should look. You should get so many glands there. But here we're
Yes,
not seeing that many glands, only few glands, and they're dilated. So actually, even though it looks like large glands, dilated glands, this is also a focus of atrophy. In this focus of atrophy, it's only chronic inflammation. In this focus, it is dilated glands. Okay, now this is another area. So here the glands look almost normal, maybe some atrophy here. What about the surface epithelium?
Below the surface epithelium, ma'am, edema.
Where is the surface epithelium? Can you see it?
Yeah.
Ma'am, denudation of surface epithelium.
Yes, so
ma'am.
surface epithelium here is
Surface
denuded.
epithelium.
What about here?
Yes.
So here the surface epithelium you can see is actually come off from below. It's come off and it's lying here free. So this is also, and if this had disappeared, we would have called it denuded. So this surface epithelium has come off, okay? So there's a certain reason why this epithelium has come off. The mucosa is little fragile. The epithelium is fragile, so it's come off, okay? So is this a true ulcer?
No, ma'am.
Finding
No,
difficult to
complicated
comment,
condition.
right? You don't know, what is your worry? Is this acute inflammatory exudate here? No, there's no acute inflammatory exudate. Is there any necrotic material here? No.
No.
Is there any IgT here? Okay, you're not sure. Let's look at the higher magnification. Okay, this is a higher magnification. Here you see this epithelium. It doesn't really look normal. Okay, there's something abnormal about it, some neutrophil here. And here, can you see this epithelium is coming off? And below the epithelium, what is this pink stuff?
Ma'am, is it amyloid-like material?
Yes, very good. It does look like amyloid. Okay, it looks like amyloid. It could be amyloid. What we need to do now is special stains. Okay, so what special stains shall we do?
Congo.
Congo red.
Congo red.
Is there anything else it could be? What else looks like amyloid? Normally, when you see amyloid, what is your other suspicion?
Collagenous crust.
Collagen. So what special stain will you use for that?
Niacin trichrome.
Trichrome. Okay. So we're going to look because there's moderate chronic gastritis with focal atrophy and eosinophilic subepithelial deposits. Okay. So this is the deposit. Inside the deposit, can you see some cells? That's a fibroblast. Maybe there's a fibrocyte. This may be actually a blood vessel inside that. This also may be a blood vessel inside the that pink material. Do you see that in amyloid? Do you see cells and blood vessels inside amyloid deposits?
No, but
No, ma'am.
acellular eosinophilic.
Yeah. You never see cells
No, ma'am.
and blood vessels embedded in the amyloid. You can have amyloid in the wall of a blood vessel.
Yes.
You will never have capillaries lying inside a large mass. Usually not. Never say never. So this is a trichrome stain. Okay, what does it show?
Blue color, ma'am. Collagen.
What does that suggest?
Collagen.
Collagen.
There's
Collagen.
a subepithelial collagen deposition. Okay, and what do you think? How much is okay? We'll go to the next slide. Now this is the spectrum. So this is normal. At this end where my arrow is pointing, there is no collagen deposition. Here in the middle, there's a little bit of collagen. Here there is much more collagen. So if I'm going to measure this collagen, how much of height do you think this is? How can we guess? So the thing about diagnosing this collagen deposit is you need to know how thick it is. Is it 10 micron, more than 10 micron? Is it 20 micron, 30 micron? How will we make out? What is the size of a normal RBC?
7.2 micron.
About 7 microns. Okay. So you look at an RBC in the field and you see how many RBCs, if you stand up, will this make up? So will this make up 10 RBCs, 20 RBCs?
10.
Yeah, maybe 10, 20. Okay. So definitely it's more than 10 microns, right? So now you know there's a subepithelial collagen band. Looks like collagen. We'll also look at the Congo red stain. This is Congo red stain. Okay. Is there anything special about this band? What color should it be in Congo red? If it is amyloid. What is the name of the color that you get with amyloid on Congo red? Anybody?
Green, ma'am.
Apple green.
That's under
Green.
birefringence. That's under polarized
Okay.
light.
Yes,
Apple
ma'am.
green. Apple green.
Apple green is under polarized light
Polarized.
Yes, ma'am. Yes.
because of birefringence.
Almond red.
Reddish pinkish, ma'am. Reddish pinkish.
Yeah, correct. You're right. What is that color called?
Almond red.
Salmon pink. Okay. That's because there's a fish in the foreign countries where the flesh has that color. So they call it by the name of that. But basically it's a pinky orange color. It's not orange. Okay. Here, this is orange. It has the same color as other structures in the mucosa. So it has no distinct color. So this is not amyloid. Okay. So amyloid ruled out. And we saw that it was collagen positive. So there's a collagen band below the surface epithelium. So diagnosis is
Collagenous gastritis.
Gastritis.
okay. Okay, so you diagnose collagenous gastritis only if the band is more than 10 microns thick. Okay, it has to have entrapped capillaries and fibroblasts. And it comes because of an autoimmune condition or because of drugs. There are two different types in children and adults, often presents with anemia or abdominal pain. Okay, on endoscopy, you see a nodular mucosa. And it can progress, often it progresses. Okay. So the subepithelial band is 10 to 25 microns at least. Irregular, in some areas it's present, some areas it's not present. Chronic inflammation is also present. There may be increased intraepithelial lymphocytes. So which is the other condition it can be associated with? Collagenous gastritis may be associated with lymphocytic gastritis. Okay, the differential diagnosis is amyloidosis and other causes of fibrosis. Okay, so to summarize what we have learned today, we learned the classification of gastritis. Okay, we learned that gastritis can be acute or chronic, and there can be special forms of gastritis. We saw a small image of H. pylori associated acute gastritis, in which there are no chronic inflammatory cells, no plasma cells, no lymphocytes. Whereas chronic gastritis, the classical forms, H. pylori associated autoimmune gastritis, are always associated with chronic inflammation, increase in plasma cells and lymphocytes. Okay, that is chronic gastritis. And then the special forms of gastritis have certain specific features. So chemical gastritis, we saw an image, no inflammation, but fibrosis in the lamina propria. Lymphocytic gastritis, the main thing is increase in lymphocytes in the epithelium, more than 25 per 100 epithelial cells. In eosinophilic gastritis, more than any other cell, you get increase in eosinophils. Okay, and then you have all the infections like TB, H. pylori, of course, is there, but other CMV, other parasitic infections, cryptosporidium can affect the gastric mucosa, syphilis, so many different infections. Then granulomatous gastritis, differential diagnosis, tuberculosis and Crohn's disease maybe, but also sarcoidosis, chronic granulomatous disease, and foreign body granulomas. So based on the entire picture, you have to distinguish between TB, Crohn's, and all the other causes. And then collagenous gastritis. Okay, now the reason why I showed you these special forms is that all these forms can also be seen in other parts of the GI tract. Lymphocytic enteritis, lymphocytic colitis. In all of them, it's more than X number of lymphocytes per 100 epithelial cells, without features of Crohn's disease, without feature of infection, without any other features. Okay, so it's only increase in lymphocytes in the epithelium. Then you can say lymphocytic gastritis, lymphocytic enteritis, lymphocytic colitis. What is the cutoff for the small intestine to say increase in lymphocytes?
40.
40, correct. So the old one was 40. Now for celiac disease, they say more than 25. Okay. What about colon? The cutoff is 20. Okay, so for lymphocytic colitis, cutoff is 20. Okay, now eosinophilic. You diagnose eosinophilic in the small intestine, eosinophilic enteritis, eosinophilic colitis, eosinophilic gastritis, eosinophilic esophagitis, only if the main and predominant cell is eosinophils. You can get a few other cells, but the main cells should be eosinophils. Okay, that's how you diagnose eosinophilic. Infections, of course, you should see the infectious agent. Granulomatous now is a big box of different conditions, but you have to look at all the other changes, and you have to look at the features of the granulomas to be able to distinguish the different disorders associated with granulomas. And then collagenous gastritis. You can have collagenous enteritis, collagenous colitis. In all of them, you have to have a collagen band below the surface epithelium, more than 10 microns in thickness, okay, with enmeshed small cells and capillaries. So in the stomach, the diagnosis is based on the etiology, it's based on the morphology, and it's based on which part of the stomach is affected. Okay, and then we learned the approach. How do you evaluate gastric mucosal biopsies for inflammatory lesions? Under LOPA, you identify whether it's body or antrum, whether there's a true ulcer or not. You identify lymphoid follicles which are seen in H. pylori. Then you identify the severity and stage, whether it's superficial or deep. Is it a mild chronic or a severe chronic? And then under HYPA, we look at the surface epithelium for features of H. pylori. We look at the foveolae for activity, which are seen in H. pylori associated, but can also be seen in other forms. We look at the glands for atrophy. We look for metaplasia, which can be intestinal metaplasia, complete or incomplete, or even pancreatic metaplasia. Then we look for chronic inflammation in the lamina propria, and H. pylori associated gastritis, autoimmune gastritis in the body always have chronic inflammation. Reactive gastritis does not have chronic inflammation. And then there is the other, all the special forms have special types of inflammation, either in the epithelium or in the lamina propria. Okay, and then of course you can look for granulomas, dysplasia, and carcinoma. Okay, so we are done for today. Any questions?
Thank you, ma'am.
Thank you, ma'am.
I'll read out some of the questions which have been typed, ma'am.
Sure.
What's the difference between GIMSA and modified GIMSA?
Okay, it's about timings and the dilution of the stain. I'm not sure about the details, but you can email me and ask me. I can find out from the lab. But basically, modified GIMSA is what we recommend for H. pylori, not the regular GIMSA.
There's another question, ma'am. What's the cutoff for eosinophilic gastritis?
Okay, so there really is no cutoff. For the esophagus, the cutoff is 15. In the colon and stomach and small intestine, some people say 40. But one of the problems of having a cutoff is, suppose you see 39. Would you still call it? What do you say? Anybody? Suppose the cutoff is 40 and you see 39. Will you call it?
Yes.
Yes, ma'am, we'll call it.
You will call it if there is no other disorder and if eosinophils are predominating. And usually eosinophils have to be both in the superficial and in the deep. It should be infiltrating the epithelium. Okay, so you have to see multiple features when you make a diagnosis. You never say based on, like lymphocytic gastritis, you will never diagnose lymphocytic gastritis in a biopsy which has granulomas. Okay, any condition with granulomas can have lymphocytic gastritis. You will not diagnose it. You only diagnose lymphocytic gastritis if there's no other disorder. You don't diagnose it if there's H. pylori usually. You will call it H. pylori associated gastritis. So any disease has a spectrum of changes, and other diseases have to be excluded before you make that diagnosis.
He has asked, can small amount of necrosis be seen in Crohn's?
Yes, it can rarely be seen, okay, but not caseation. What's the difference between caseation and any other kind of necrosis? Anybody? Caseation actually has fragmentation, granularity. It has a small, the nuclei and the cytoplasm breaks up into rounded, tiny structures. Okay, it's dot, 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 dot. Regular necrosis will not have dot, 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 dot appearance. The nuclear fragments as tiny round structures is seen classically in caseation. In regular necrosis, either it's just a pink mass or it'll be a random kind of structures and shapes. But to have the dot, 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 dot appearance is the classical appearance of caseation, granularity or a dot, 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 like apoptotic bodies.
There's a request. Please elaborate on all metaplasia seen in gastric biopsy.
Okay, so basically it is either intestinal metaplasia or pancreatic metaplasia. But in the body, when you get the antral type gland, that is called pyloric metaplasia or pseudopyloric metaplasia. It's not real pyloric, it's pseudopyloric metaplasia. And the way you can make out pseudopyloric from pyloric is by looking at the endocrine cells. You need special stains. But you can also do based on the pepsinogen that is expressed. In the body glands, the secretory cells produce both pepsinogen 1 and 2. In the antrum, they produce only 2. So it's a bit difficult to make out pseudopyloric from pyloric, the real pyloric glands. But if you know where the biopsy is from, you should not see antral or pyloric type glands in the body. When you see antral type glands in the body, that's called pyloric metaplasia. Intestinal metaplasia is easier to make out. So you get complete intestinal metaplasia when all the cells in that area are of the intestinal type. So there are multiple cells in the intestine. There are the absorptive cells that don't have any mucin. There are the goblet cells which are full of mucin. And then there are the Paneth cells at the bottom of the crypt. Okay. And the other additional feature of complete intestinal metaplasia is that you will be able to see a brush border. It's a small refractile edge on the luminal surface. So complete intestinal metaplasia will also have the acidic mucin and Paneth cells. Incomplete intestinal metaplasia is when there are gastric type epithelial cells or gastric mucin interspersed with intestinal mucin. So if you do an alpha stain, some of the cells will have neutral mucin, some of the cells will have acidic mucin. Okay, and incomplete metaplasia can have with small intestinal or large intestinal. So if it's large intestinal, it will be positive for sulfomucin, which is high iron diamine. The sialomucins are positive with alpha. So by using these special stains, you can make out whether it's complete or incomplete, because in complete, you will not see gastric type neutral mucin. In incomplete, you will see gastric and intestinal, neutral and acidic. Okay, and the incomplete is a dangerous one, which can go on to dysplasia and carcinoma. Pancreatic metaplasia is usually harmless. It doesn't have that intestinal type mucin. And if you do the chymase and trypsin stains and all, you will pick up pancreatic acinine.
Yes, ma'am. The next question. Can we use the scoring system if biopsy from only one area of stomach is given?
Yeah, the scoring system, see, you can always say whether there's chronic gastritis or not. You can always say how much of activity there is. You can always say how much of atrophy, how much of intestinal metaplasia. So to say all these things, you don't need all the biopsies. And ideally, they shouldn't mix body and antrum. That is not good, because if you mix up body and antrum, you can't make out pyloric metaplasia in the body. You will not know whether it's body or antrum in an autoimmune gastritis. So if your clinicians ask you, tell them to put the biopsies in separate, body and antrum separate. Okay, but otherwise, if they just mix it up and give it to you, all you can do is say how much of gastritis there is, say how much of intestinal metaplasia, activity, pyloric metaplasia. And the clue to chronic or autoimmune gastritis, sometimes you might see those endocrine cells in the base.
The next question. Does regenerating glands indicate activity?
Do regenerating glands indicate activity? Most of the time, yes, because regeneration happens because of damage. When there's damage to the cells at the top or in the foveolae, then the stem cells will start multiplying. When the stem cells multiply, there's regenerative change. Okay, so usually it means there's injury, which is because of activity. But in a reactive gastritis, you don't see neutrophils much, but you see regenerative change because it's a chemical injury. The chemical injury damages the surface epithelial cells and causes regenerative change, but often it doesn't cause any neutrophil infiltration. It's like a sterile gastritis. So reactive gastritis, no neutrophils, but regenerative change. All other forms of gastritis, regenerative change is usually associated with neutrophils.
Thank you, ma'am. I think I've not missed any questions. Yeah.
Thank you so much, Anna. I think you've had, I don't know if you're looking at the chat box, but lots and lots of praise and things like amazing session, etc. I must say that it was very succinct and extremely explanatory. So I thank you very much. I think when I was listening to the students answering questions, they have somehow or the other, with the 3 lectures or 4 lectures actually now, have been able to imbibe a lot about the histology, morphology of the gastrointestinal tract. And I'm so glad that the students were so confident, in identifying what was the body, what was the antrum, etc. So good, full marks to the students. And of course, if you have a teacher like Anna, then the full marks become super marks. So thank you so much, Anna. It was really
Dr. Anita. And I want to congratulate the students, because when I talked to them at the introductory session, none of them had seen mucosal biopsies. And here they are answering all the questions. I told them to read up, and they read up and they were able to do it on their own. I think that's excellent. That's how you learn pathology, and it teaches us that anybody can learn anything.
No, it's true.
Thank you, ma'am.
It's true. So I think really the students have done exceedingly well, and I must say, Anna, that they will be happy that you sort of gave them the foundation on which they can build. Thank you.
Thank you.
I have to thank, apart from the students and Anna, I have to thank